So welcome all. Thank you for joining us for our outpatient pre-course. I hope that this is a restorative weekend for you, and it's full of learning, and hopefully get to reconnect with some colleagues, maybe that you've seen recently or not seen for some time. And thank you for being here. So I'm just going to run through some disclosure slides. This is our 2025 meeting. A few disclosures from our presenters, both for the inpatient and outpatient pre-course. Let you read those. This is our anti-harassment policy for ACP, and you'll have access to this if you want to review it. And then this is the college's Education Content Validation Committee and their disclosures, which it looks like there are none. For CME, you'll go to the pre-course hub, which is the link that you use to access the Zoom link. And there's a button there to claim your CME credit and AMA credit if you need that. And then QR code, your feedback. Doesn't look like the QR code is here, but I'll have Steve share that. And this is a little bit another blurb about CME. Cool. So I'll let Radhika put up her slides and I'll introduce her. Thank you so much for joining. So Radhika Narla, Dr. Narla is an endocrinologist at VA Puget Sound, an associate professor at the University of Washington. Her research focuses on osteoporosis and male hypogonadism in veterans, addressing care gaps and improving screening. She co-directs the VA's osteoporosis clinic, leading initiatives like nurse-led medication management and pharmacy dashboard tools. She's also Associate Program Director for the University of Washington Internal Medicine Residency, and she's committed to subspecialty education and mentoring physician scholars. Radhika, thank you for being here. Your slides look great. I'll let you take it away.
Thank you. Thank you, Sri and Tess, and for ACP for having me come and speak to a topic that is very near and dear to my heart. I am very passionate about this and trying to help everyone, including our frontline clinicians, kind of feel better equipped to address this topic, both in the inpatient and the outpatient settings. Just a little bit more on my background. So as Sri shared, I'm a clinician scholar and endocrinologist by trade, and I'm very fortunate to have met my partner in crime at work, Katie Weisham. She's a rheumatologist and a physician scientist. So it's a perfect marriage of sorts where we've kind of come together. We were able to get whole health funding for a physical therapist in our clinic, so Rosalind joined us. And then we have an amazing rock star of a nurse coordinator, Christian Stepp. So you can almost say like the Fantastic Four. We've led some quality improvement initiatives, really looking at ways to optimize care delivery, interdisciplinary team models. So it really is a joy and the true essence of working with these amazing colleagues. So I just wanted to give a token of gratitude and share a little bit more background of our philosophy in this clinic, as well as some of the philosophy you'll see today that I'll share. So this is a new disclosure I just wanted to mention. I am part of the ACP Mix-Up Core Committee for Endocrinology, so I just wanted to mention that. When I was putting this talk together, I really wanted to kind of address some of the key hot kind of emerging topics for all of you today. Wanted to make sure that this was apt for, again, people that are inpatient, outpatient, and ensure I cover the right content. And so with Sri and Tess' help, we kind of narrowed it down to 3 high impact topics. First off, I want to give you the tools to kind of address IV zoledronic management. This was one of the requested topics, and kind of give you some nuanced clinical pearls and like practical tips that comes up in the inpatient setting with that. This is also very much an emerging hot topic in the bone mineral field. It's really about championing, partnering with primary care colleagues to really help identify patients that would benefit from anabolics first. And so I really want to kind of, again, highlight the concept of risk stratification and which patients we would love to see in the osteoporosis clinics. And then third, this was such a hot topic in our American Society of Bone Mineral Research this year, which actually was in Seattle. And so while I can't span the whole diabetes and bone pathophysiology, I just wanted to talk about and give you an update on GLP-1 receptor agonists in bone, because I think there's going to be more to come about this. So these are the three kind of high impact topics we'll cover. So without further ado, to empower you all, I'm diving into our first question. And yes, this is not a mix-up, formatted question, right? It's just to get the pulse of the audience going. And so my question to you is, would bisphosphonates soon after a fragility fracture in the inpatient setting, should that be done? Do we give it? Do we not give it? What do you guys think? So it's only three answer choices. A is yes, you give. B, you shouldn't give. Or C, probably the safer answer, I know, controversial. I'll give you a little bit of time to marinate on that. And Sri and Tess and Steve, if you can tell me when we've got some answers in the poll. This is where I wish I had some music in the background.
Steve, are you able to launch the poll? I don't know that I see it on my end.
Shows that it's launched.
Okay. Tell us
Or
if
put it in the chat, right? If you guys feel comfortable, put it in the chat, A, B, or C.
oh, there
Okay,
it
I
is.
see the poll now. Cool. I know this often comes up for when you're on the inpatient setting, especially, or when you see a patient afterwards in the outpatient setting, right? So I'm just curious to get a pulse of the panel right now and see where you guys think about this.
Awesome. We can close the poll and see what the results look like.
Oh, wow. It's a smattering of answers, more towards A and C controversial. Cool. Okay. That is great that we have a smattering of answers. Actually, this is perfect. And I'm actually, Sri, it's good that you asked me to talk about this topic. It really challenged me to look up the current data as well. So thank you for asking me to talk about this, because I get it. It's tough, right? Is it good? Is it bad? Right? We've heard different things, right? You have a patient in front of you, they're a candidate for IV zoledronic acid, and you obviously want to give them that agent so that you can prevent future fractures, right? And decrease their morbidity and mortality. But at the same time, right, you've been kind of maybe heard or told that that could delay wound healing, right? And so what do? Is it wound healing? Is it preventing fractures? And so I get the conundrum here. And so my hope is to kind of talk about healing implications and exploring timing and some of the questions that come up with giving IV Zol in the inpatient setting. So typically, what are people worried about, right? This concept of delayed healing, or what's often called like a delayed non-union. And I'm just using hip fracture as an example. Obviously, you can apply it to the other fragility fractures. And so when someone says like a delayed healing or non-union, they're often referring to symptoms, clinical symptoms, so pain, inability to ambulate, any gait disorder 6 weeks after a surgical repair, after like a hip fracture or so forth, as well as radiographic findings. So I'm just giving you two examples here in the arrow that I liked. In the thin arrow, what you see, hopefully you're appreciating this line that's going across. And what you're seeing is this is a 6-week post-surgical repair x-ray, and you're still seeing that persistence of the fracture line, right? Without any change from the initial radiograph. So you're worried that there hasn't been healing. As well as here in the larger arrow, what you're looking for is kind of some callus or new hardened bone formation, and that's not happening. So this is some of the examples when an orthopedic colleague says they're concerned about non-union or delayed healing. But interestingly, when I looked back, there are many studies to say, actually, not just from osteoporosis colleagues, but also from the orthopedic colleagues, that there is no delay in fracture healing or increased non-union rates when you give bisphosphonates. So they looked at this in rat models. They gave the Zol 1 day, 1 week, or 2 weeks after, and it didn't impair fracture healing. And then when there was a post hoc analysis in the Horizon study, which really had a large sample size of patients that got IV zoledronic acid, given at various intervals, including that 2-week window, there was again no association between delayed fracture healing or any increased rates of non-unions. So that's interesting, right? And what's also even more piquing, hopefully, many of your interest is there's been a revitalization of looking at this in recent years. And so Benjamin Leder in Harvard, his group has published a couple papers, actually, I'm just showing one of them, really looking at the safety of inpatient Zol immediately after a fracture. And what I really like about this paper is it's addressing a lot of those questions that comes up for the orthopedic colleagues as well as us internists, right? Your concerns about fever, a drop in calcium, or any renal dysfunction that could be associated with IV Zol if you give it in the inpatient setting, right? So some key pearls here is a common side effect after IV zoledronic acid is this acute early phase reaction, where the patient will have symptoms like flu, myalgias, bony pain. Pretty much, I tell the patients it's like you're getting the flu. In my practice, I would say up to 30% of the patients will experience this. It's usually diminished on the second infusion, right? But obviously, you all can appreciate this would make people nervous, right? A fever? Is it a fever related to the Zol? Is it a fever related to some kind of an infection? Is it going to delay discharge, right? Which is an important metric, and so on. So that's why I chose to kind of present this paper and talk about the practical clinical nuances. So what they did was they did not include patients with like ankle fractures or anything like that. So these are fragility fractures. They used the cutoff of patients who are eligible to enroll if they had a vitamin D level of greater than or equal to 20. Some of you may say, isn't that a little bit too low? Isn't the cutoff 30? That's a whole nother talk, the controversial of the vitamin D levels, but they used the cutoff of 20. Again, another little pearl, you cannot use IV zoledronic acid when the eGFR is less than 35 in patients. So that was the cutoff that they used. They didn't give IV zoledronic acid in the intervention arm to any patients who had an acute drop in their kidneys. So if there was any creatinine increase, they didn't give those patients the zoledronic acid, as well as made sure that there was no drop in the calcium post-operatively. So those patients weren't enrolled. And so what they did was, again, they enrolled patients in the intervention arm to get IV zoledronic acid. Another interesting caveat that I want to mention is all of the patients got vitamin D and calcium, whether they were in the control arm or the intervention arm. Okay, so just we'll put that in the parking lot and come back to that. Comparative group, obviously, they received standard of care with IVs without IV Zol, but they still got vitamin D and calcium. Within the intervention arm for the IV Zol, interestingly, they had two arms. They had patients who got a single dose of Tylenol before the zoledronic acid infusion, and then they had multiple Tylenol doses that were given before the IV infusion and after up to 48 hours. The theory behind this, some of us, when we have patients that are very nervous about the side effect, this is a bit more of an art than a medicine, but we will pre-treat them. And part of that pre-treatment is Tylenol. So this is why they tried this and looked at the intervention arms like this. Again, this is a secondary fracture prevention study. They had 204 patients enrolled that got the IV zoledronic acid and then separated them into single Tylenol, multiple Tylenol doses. The other thing I really wanted to highlight was very interesting when I read this. They gave the zoledronic acid over 45 minutes. Why do I say that? Typically, when I order Zol to be given in the IV clinic, it's actually given within 15 to 20 minutes. In patients where I'm worried, where they have some CKD, or they're worried about the acute phase reaction, that's when I have to ask the nurses to give it longer. So they ahead of time gave all the patients a longer duration of the IV zoledronic acid. So I'll come back to that in just a second. And then this is what I'm going to show you, the results when it comes to the temperature, creatinine, and calcium, what happens, so you have an understanding of some of the practical things that'll come up. It's a busy slide, but I'll walk you through it. What they did was, what I'm showing you is this is the patients who didn't get the Zol, so the control group, single Tylenol but got the Zol, multiple Tylenol doses and got the Zol. This is day 1 before Zol, day 1 after Zol, that's what the A stands for, and then day 2 after Zol, day 3, day 4. Some of the key concepts to take away is the patients had higher body temperatures statistically when they got the Zol versus they didn't get the Zol. So the authors say you should expect a temperature increase. The second thing is the single Tylenol versus the multiple Tylenol dose, there was definitely a statistical difference in the temperatures, with the single Tylenol groups definitely having more rises in their temperatures. Interestingly, the multiple Tylenol dose did not experience that mean increase in their temperatures. So the authors say perhaps this is something that we can include in the protocols to make sure they get the Tylenol. And I'll show you this did not increase their concerns for infection that was being missed. This didn't increase their readmission rates or anything like that in this group. The second thing is, what's interesting is post-op about day 5, the patients that got the zoledronic acid, regardless of the Tylenol dose, did see a mild dip in their calcium levels by about 0.54. And remember, all of the groups got vitamin D and calcium. But the key takeaway is it was transient. You can see the calcium recovers, right? And I'll show you this in my next slide. None of these patients had any postoperative hypocalcemia that required acute management or anything like that. It was just observed, and then again, they responded. I didn't show you the creatinine, but there was no increased AKI in these patients. So again, these are the questions that often come up, right? Giving Zol in the inpatient setting. And I use the study to advocate that it is well tolerated in patients, perhaps considering standing acetaminophen to eliminate some of those acute responses. No increased kidney injury. The calcium, the drop was mild, but it was transient, and that's the key thing to take away. And again, these patients all received vitamin D and calcium. And then finally, like I said, no symptomatic hypocalcemia, no delays in discharge, and no increase in 30-day readmission rates were reported. So, and then finally, again, their infusion rate was much longer that they gave the IV zoledronic acid. So perhaps that's something that we could also consider. So really, the other thing I wanted to mention is I looked for data of giving Zol 3 days, 1 week, or 2 weeks post-fracture, and that's very limited in terms of exact timing. But most of the evidence really supports either during that initial hospitalization or within 2 weeks to give IV Zol if the patient meets criteria for IV zoledronic acid, as long as the renal function and the vitamin D is appropriate. So I hope that helps to kind of uncover some of the myths and demystify it. And obviously there's a place for IV Zol. There's going to be quite a number of patients who's going to benefit from IV Zol. But I question and I wonder, and I'm curious if you guys think, should everyone post-fracture in the inpatient setting get IV Zol? What do you think? I don't know if anyone wants to put it in the chat, but should we just automatically give everyone post-fracture IV Zol? The answer is not exactly. I think this is where I wanted to turn to my second learning objective and talk about risk stratification and really bring up this point that there are certain patients that will definitely benefit from IV zoledronic acid. But then there is another set of patients that may benefit from an anabolic agent first, whether that's a PTH analog or romosozumab, right? And I don't expect our primary care colleagues to know exactly which one, but I'm hoping in a broad stroke, you're able to feel, empowered to know which patients we might consider referring to your osteoporosis friends. So with that, I'm going to move on to our second question to help kind of demystify some of that and talk about this concept. So let's say you have a 57-year-old woman in your clinic. She's postmenopausal. She has a history of multiple compression fractures in her back. And this is after ground level falls. The most recent one was 1 year ago. Menopause was at age 49, and she never took hormone therapy. You've ruled out secondary causes of osteoporosis, and you have our latest DEXA report, which shows the lowest T-score at the total hip of minus 2.7. Again, I'm not expecting you all to know exactly the sequence orders and all of that, but I put it in this way in the question because I want to go over the different options and kind of give you some pearls. So I'm curious, what do you guys think? Is this something that your osteoporosis friend would say, do A, alendronate, abaloparatide, and then a drug holiday? Would your osteoporosis colleague say B, denosumab, and then abaloparatide? Would they say C, romosozumab, zoledronate, and then a drug holiday? Or would they say D, denosumab, and then a drug holiday? I'm just looking outside my window and it's pouring out there. Hopefully everyone's safe and warm. Let me know, guys, when there's enough responses and we can close the poll and take a look at it. Okay, it looks like we've got answers for A, some of them, but most of you guys actually said C, and that is the best answer, so kudos. I'm going to walk through each one and actually give you a little bit of pearls and takeaways for each answer. So A, I'm going to tell you, while this often happens in practice where you get the anti-resorptive first, and then for various reasons they need the anabolic, my hope is to really highlight that sequence matters, which is very unique in osteoporosis, right? It's very different from blood pressure meds, diabetes meds, and so forth, where if you give a certain drug first, you're going to get the optimal bone density gains. And so I'll talk about that. And then the key thing that why A is also not right, abaloparatide not only activates the bone forming cells, which are the osteoblasts, it also activates some of the bone resorbing cells, so your osteoclasts. So you have to sequence it with an anti-resorptive. So it's not a medication you can give and then put them on a drug holiday. B is not the right answer because a couple of years back, there was the data switch study that said that denosumab followed by a PTH analog is not the best for bone density gains, okay? And then finally, D. I won't have time to talk about denosumab, but my key pearl for you guys is I know with bisphosphonates, there can be drug holidays, but for denosumab, there is no such thing as drug holidays, okay? You have to sequence it with an anti-resorptive, or for certain patients, it's a lifelong drug. It's very confusing, the concept of denosumab, but basically my key takeaway is it's not a drug that you can abruptly stop. If the patient stops taking it or you stop denosumab for any reasons without sequencing it with another drug, they're at risk for atypical femoral fracture, okay? So with that, I wanted to really talk about which patients would benefit from an anabolics first. I think this is the most important concept for our frontline clinicians, so all of you today. In the past, right, everyone got a bisphosphonate. That was pretty much it. What I'm here to tell you is that's an older paradigm, and there's a shift in paradigm now. And there's a shift in that paradigm for two major reasons that I want you to take away today. One, this concept that once a patient has had a fragility fracture, I'm going to show you the data, they're at the highest risk for a future fracture. This is what we call now imminent risk, especially within 2 years. So I'll talk to you about that. And then again, I've already started talking to you that in osteoporosis, we're unique in that the sequence and the order of the drugs matter. And I'll talk to you about that too. So again, shifting away from this paradigm. There are patients that would benefit from a bisphosphonate. Please don't get me wrong, especially IV-Zol or oral alendronate. But then there are a group of patients that would benefit from the anabolic first. So I'm going to briefly show you this study a couple years back. It's a systematic review and meta-analysis. I think it had 13 or 14 studies globally. And what the key takeaway that I'm going to show you is that once a patient's had a fragility fracture, their incidence of having another refracture is very high within the first 2 years. That's huge, right? And so really emphasizing the need for partnership of all of us to be helping reducing the morbidity and mortality for these patients. So briefly, they showed that the 1-year risk for another refracture is 7.6% globally. That rate increase goes up to 11.6% within 2 years, really emphasizing the importance of monitoring and preventive measures during that period. A higher risk for women globally versus men. And there's geographic differences, right? Asian countries a little bit lower risk, with Europe and North America going to about 13.2%, again, showing the diverse healthcare needs. So again, there's obviously limitations, right? There's heterogeneity among these study populations. There was some heterogeneity about fracture definitions, follow-up durations, right? More studies in North America, Europe, and Asia, and some perhaps not equal representation globally. The study didn't address impact of specific interventions, right, for imminent fracture risk. But again, I really wanted you to take away this risk of refracturing after having a fragility fracture, especially within the first 2 years. And I think all of you, I'm preaching to the choir, right? Many studies to show that our older patients, right, they're more frail, they have more comorbidities, they have higher falls risk, their physical mobility is down. And many studies have shown, again, a higher incidence of having a refracture in our population that are 70 to 79 versus 50 to 59-year-olds. So this is important to take away. And so, okay, we have these patients, once they've fractured, they have a high risk of imminent fracture. Okay, well, why can't I just give bisphosphonate to them and just make it easier, right? Because sequence matters. So what I'm showing you here is, this is the ARCH study and this is the FRAME study, and this is the change in total hip bone density. Very similar pattern if I showed you the lumbar spine. I just didn't put it in just to make this visually easier to follow. And what the ARCH and FRAME study showed was that if you gave de novo patients romosozumab, so in the green, first romosozumab, and then follow it up with an anti-resorptive, so sequence it, you get up to 6% gains in the bone density and up to about 11 to 12% bone density gains in the lumbar spine. So huge increases, right? But if you gave patients alidronate and denosumab and then gave them romosozumab, so in the orange and the blue, you do still see bone density gains, but clearly you all can see it's much less, it's blunted, right? And I do recognize these are smaller studies, so I understand it's a little tricky, but there are many studies to show this and to show that if these patients get alidronate or denosumab, what are they? They're anti-resorptive, right? They're inhibiting the osteoclast, they're inhibiting bone remodeling. So the main concept here is you're decreasing your ability to build bone. And so that's why giving the anabolics first to certain patients that are super high risk is very important, right? You can improve the bone density, improve the bone quality, decrease their fracture risk, and even get some patients improvements in T-scores, right? I have seen it. I've seen their T-scores go from osteoporosis to low bone density. It's amazing and just super rewarding to see. So before I go into an algorithm that came out last year, I just briefly wanted to give you some high yield pearls to know when you're talking to patients about PTH analogs and romosozumab so that you feel empowered to have some of the initial conversations, verify with the patients, and then absolutely would love to see these patients in referrals. So PTH analogs, how do they work? Briefly, they activate the PTH receptor in a pulsatile fashion. That's the difference between that versus in hyperpara. It's not a continuous catabolic. It's a pulsatile, so that activates the bone forming or the osteoblast cells. I do not give these patients PTH analogs if they have severe CKD, especially stage 4 or 5, because they have usually hyperparathyroidism. I don't give them with significant kidney stones history. And I don't give these to patients with recent, especially like prostate, breast cancer with radiation exposure. A couple years ago, the risk of osteosarcoma was removed as a black box warning. And so that means that perhaps osteoporosis physicians can give multiple courses. I haven't done that yet. I think it's a very judicious, individualized decision to give repeat courses. The key things to remember is this is an injection that the patient learns to take by themselves after they receive teaching. And so this is done at home that they can do the injection. Now, I understand a big part of this is formulary and costs, and can you get it, insurance companies and so forth. I have some numbers here. Again, it varies by formulary if teriparatide or abaloparatide is preferred. Teriparatide is a daily injection for 24 months versus abaloparatide is a daily injection for 18 months. Again, cost is kind of the main factor driving this. Abaloparatide doesn't have to be refrigerated. So I just want to give you a tip. If I have a patient with housing insecurities, I'm able to request for abaloparatide. I just have to advocate for it. Another quick pearl. This is the only class that doesn't come with the risk of atypical femoral fracture or O&J risk. And so in some cases, if I have patients who I deem as very high risk, so I risk stratify as very high or imminent risk, and they do have dental work and dental is worried about it, I have gotten abaloparatide or teriparatide approved for that specific reason. And that allows us and buys us some time for their dental work to get done before I sequence it with an anti-resorptive. But it requires a lot of buy-in from the patients, a very shared decision-making with them that we should be having with them. I don't anticipate our primary care colleagues to feel comfortable with that. So those are some quick tips to know for you guys as PTH analogs. What about romosozumab? Romosozumab inhibits sclerostin, which then activates the bone-forming cells, the Wnt signaling pathway. This is a once-a-month injection that is only approved to be given in a healthcare setting. So it's usually given in an osteoporosis shot clinic in a hospital setting. It's once a month for 12 months, and then again, you also sequence it with an anti-resorptive. In some formularies, it's actually cheaper than the PTH analogs. Again, it varies. Usually it's reserved for patients that are much more risk stratifying towards the higher risk. We're still trying to understand this possible MI and CVA risk, but there is a black box warning that I cannot give this to a patient who's had a heart attack or stroke in the past year. Okay, so those are some differences comparing and contrasting the two anabolic agents that I wanted to make sure I share with you today. Okay, so I have said there are certain patients that would benefit from the anabolic first, right? I said sequence matters. They're the highest risk for a refracture. Who are those candidates for anabolics? And so it's a quite extensive goal-directed osteoporosis treatment position statement that comes from American Society of Bone Mineral Research and the Bone Health Osteoporosis Organization. But what I wanted to distill and share with you is when you have a patient in front of you, okay, when you're starting off, ask the question first, have they fractured, like a true fragility fracture or not? If they haven't fractured, this is where assessing the risk factors. Do they have very low T-scores? Are there a high risk of falls? This is often forgotten by us, right? No matter what drug you give, if you don't prevent the fall in the first place or recognize that they're a high risk of falls, you're not doing justice. Do they have secondary osteoporosis risk factors? Do they have early menopause? Are they on glucocorticoids and so forth? And again, if they haven't fractured and they're high risk, this is where it really then depends on, again, the individual patient's preference, but that guidelines advocate either an anti-resorptive or an anabolic. But the branch line is if they have fractured, then we're going towards the anabolic state, right? And if they fractured, the next question to ask is, when was these fractures or fracture? Was it greater than 2 years ago or within the past 2 years? Because again, these guidelines share that if it's greater than 2 years ago, they still would be classified as high risk. Why? They've already shown to you, they've already signaled to you, they've had one fragility fracture. There is some kind of compromise in their bone architecture and bone quality. These patients are high risk to refracture, guys. And so again, I understand the formulary criteria, but really there has been some changes in formularies and their understanding of these guidelines as more and more people are advocating for this. And so again, if they have a lot of risk factors, multiple fractures, very low T-scores, they're falling, consider anabolic first. And then again, if these patients, like my question stem lady who had a recent compression fracture a year ago, those are the ones that are at imminent risk, and they would really benefit from an anabolic first. The anabolics reduce their risk of fractures up to 50% with the anabolics. So hopefully this algorithm simplified really helps you to think, again, have they fractured? When was the fracture? What are the risk factors clinically for bone loss and for falls? And so more of us are moving away from this kind of one-size-fits-all bisphosphonate paradigm and really risk stratifying the individual patient in front of us. But I think all of you know, right? We're juggling so much. We have a patient in front of us. We have the evidence-based guidelines. We've risk stratified them as an imminent risk. We've talked to them about the risks and benefits, but we have to bring the patient in, right? And this is where we're happy to have these conversations, right? There are some patients where coming to the shop clinic once a month is a significant barrier, right? Or there are some patients who are going to say, I would just want the IV zoledronic once a year, for 3 years first. And that's okay. We're happy to have those conversations. Give these patients a chance. Even if it's a one-time, I see these patients, right? I give you the recommendations, I hand it back to the PCP. But that's what I'm hoping, that we welcome and have these conversations as primary care, as subspecialists with our patients together. Awesome. I'm a big believer that I share theory and then I apply it to clinical application. So right before my slides were due, I saw this patient with one of our fellows actually in clinic right before Halloween. So this is not a pose question. So Steve, you get a break. But what I'm hoping to do is you can put it in the chat, or if you feel comfortable, just shout it out. I don't know if you can unmute yourself, probably not. But I want to go through a case and I want you guys to think about, what would you ask the patient? Okay. So I have a 61-year-old male in front of me, and he has ongoing tobacco use. He's smoking, I think, half a pack a day. He used to smoke more, but previously. And he had some lung cancer CT screening done, and it showed low bone density. And so his primary care did their diligence based on, the pulmonary recommendations and got a DEXA. And lo and behold, his lowest T-score is minus 3.1 at the L spine. So I'm curious, and please put it in the chat. What questions do you want me to ask me? What do you want me to tell you about this gentleman that's sitting in front of you in clinic?
I'd love to know his fall risk.
Okay, yes. So Sri, he has a gait disorder. And again, I value our neurology colleagues. He's actually seeing neurology and getting worked up for this ataxia and gait. And no joke, he told me this. He's like, I pretty much know how to fall to make sure I don't fall, and I'm falling once a week, at least, is what he said. So this is where I use this term professional faller. And so because of this ataxia workup, he's falling quite a bit. Good. What other questions do you want to ask me? There's something in the chat, Sri, and I can't see it. Would you mind?
Yes. Any need for corticosteroids for asthma or COPD exacerbations?
Yeah, no history of corticosteroids that he's aware of, that he remembers. He doesn't have any advanced COPD, so he's never been admitted for that. Good question. I love it.
History of fragility fractures?
No history of fragility fractures. Wonderful. Super.
And then any pertinent medications like antiepileptics, for example?
No antiepileptics. Wonderful. The older classes are the ones that we're worried about, so terrific. Anything else?
Family history of osteoporosis?
He was not aware of this. This is the first time he's finding out.
And then history of kidney stones?
No history of kidney stones that he's aware of. No history of renal dysfunction. Awesome. This is great. You guys are amazing. Go ahead, Sri. Was there something else?
That's all we got.
Awesome. So other things that we ask in our clinic, we look back at the vitamin Ds, and interestingly, he actually had single-digit vitamin Ds around his 40s to 50s. He's been at the VA for quite some time. And so they were single digits, and they have been repleted, but it took some time. And so now I think it was 27.3 when I saw him last week. He's got ongoing tobacco use, so that was there. And then other risk factors, He doesn't have a personal history of any malignancy, so that CT screening was negative. He doesn't have any periods of immobility. He doesn't have any GI disorders or malabsorption. And again, as I told you, and Sri asked right away, he's a professional faller. So I'm curious, using the algorithm we talked about, where would you put him at? Anyone brave?
I think high risk.
Yes. Awesome. Super. Yes. Fracture? No. And then what are his risk factors for falls? Clinical risk factors for ongoing bone loss. And he definitely has a few, right? He's got tobacco use. He's falling once a week, he tells you. The other thing, this is a whole nother topic that I unfortunately didn't cover. It's a passionate topic of mine, secondary osteoporosis workup, when to initiate, when not. And I think it's really a gestalt. Do I have enough reasons to say that I know why this patient has osteoporosis? And in my head, I just wasn't sure if osteomalacia, the ongoing tobacco use, was enough with that kind of a level of T-scores. And so when I started asking him androgen deficiency questions, interestingly, he started to tell me, I do have decreased morning erections and I have low libido. And he wasn't, and this question comes up, right? What is his BMI? His BMI was not on the elevated side. And so this is when I did actually order fasting morning testosterone labs on him, and I'm waiting for those to come back. So I wanted to mention that in terms of the evaluation and teaching points. And again, this is another topic I'm happy to come back to talk to. I know there was the New England Journal paper that came out that said that there wasn't any benefit with testosterone in terms of fractures. If anything, there was more fractures in the androgel group. But if you read the commentary that comes after that, they did a very nice job. And if you look at the supplementary index and compare the androgen group and the non-androgen group, the control arm, in terms of what types of fractures they had, there was no difference in terms of fractures that you would call major osteoporotic fractures, spine, hip, all of that. What you actually saw was that the androgel group had more ankle fractures. That's interesting. And there's other limitations to that study from Snyder et al. That I just wanted to point out. So the takeaway is, if let's just say this patient, his testosterone levels are truly low, biochemically he has hypogonadism, I would start testosterone to improve bone quality and architecture, and I would add an osteoporotic agent that has been shown to decrease his fracture incidence. Okay, so that's the key pearl here. So in this patient, he definitely comes up into the high risk arm. I talked to him both about the anabolic and anti-resorptive, and he chose the anabolic, and he met our criteria, and it's already been approved that he can get the teriparatide. But again, I've had so many patients who don't want to take daily injections for whatever reason. And in that case, I would have gone with the bisphosphonate for him too. I would have just documented that he declined. So again, I think bringing in the patient and making sure you choose the agent that they can be adherent with and most successful with is really the cornerstone to help them reduce their fracture risk. Awesome. So again, I want to make sure I highlight that if they've had prior anti-resorptive, it's not a contraindication to anabolic. It's just that we want to maximize their bone density gains. So that's why certain patients could benefit from the anabolics first. And that's why you all come in and why I love championing and advocating for this. So please, please, please refer them to your endocrine, rheumatology, nephrology colleagues. We're happy to see them. And again, we can help figure out the formularies and all of that jazz that comes in it. Awesome. All right, our last and final high yield topic. This is a new one for me, so I'm super excited to do this. You all have so many patients with diabetes and osteoporosis, right? So I'm asking you the question, which diabetes medications are safest for bone health and least likely to increase the fracture risk if you had a 71-year-old patient with type 2 diabetes and osteoporosis in your clinic? Is the group of classes A, thiazides, TZDs and sulfonylureas, B, TZDs and metformin, C, metformin and GLP-1s, or D, sulfa and GLP-1s? hopefully this comes up. And I know a lot of times we don't think about this. And so I'm hoping that we kind of empower ourselves to think about this. Do I have them on the right agents? And wow, awesome, super, yes. And let me go through. C is the best choice. TZDs, there are actually studies to show that they increase osteoclasts and decrease osteoblasts and increase fracture risk. So I challenge you to kind of review your patients' lists and reconsider if they're on that and they do have a diagnosis of osteoporosis. I still see time to time sulfonylureas on patients who may have CKD, elderly, and I think all of you are very familiar with the risk of hypoglycemia and then increased risk of falls. So again, that's not a class that I generally would want to see a patient who has osteoporosis on. Metformin is neutral. So again, it doesn't increase the fracture risk. I didn't have it here, but just a quick mention on SGLT2s. I know that there was I think the Canvas study with canaflosan that brought some question, but follow-up subsequent studies have shown that they're neutral for fracture risk. And then the GLP-1s I wanted to talk about. Interestingly, if anything, they are neutral. They don't increase fracture risk. And there's some interesting data coming out that could they actually be bone protective, which is why I wanted to bring this up topic and end with this topic today. So let me talk about specifically GLP-1 receptor agonists and this question of if they're actually protective on bone. So broad strokes, right? The theory behind this is insulin actually helps to differentiate your bone-forming cells, the osteoblasts, from pre-osteoblast precursors to mature osteoblasts and help with bone formation. Now, I think many of you are familiar with type 1 and type 2 diabetes. There's this increased risk for bone health, but there's actually a little bit of characteristic differences between type 1 and type 2 diabetes. In type 1 diabetes, you guys know it's an insulin deficiency, right? And so again, a decrease in osteoblast, and many of these patients actually have low bone density compared to their age-matched counterparts. Versus in type 2 diabetes, the mechanism is a little bit different. Most of them actually have normal or even increased bone density, but what ends up happening is with the increased glucose levels, you get the advanced and glycosylated end products, and that's really affecting the bone quality. It's affecting the collagens, it's affecting the osteoid mineralization, it's increasing your cytokines and everything. And so it actually puts them at increased risk for this concept of bone fragility and increased fractures. So again, both of them different effects of diabetes. So a little bit of different characteristics I wanted to mention to you today. So GLP-1s, great drugs, right? A lot of you are using them, again, pending the formularies. They increase insulin release and suppress glucagon. And many animal models have actually shown with GLP-1 RAs, especially liraglutide, there might be some increased bone formation, which is why this was really a hot topic at our American Society of Bone Mineral Research Conference, which actually was in Seattle this year. And so what I'm sharing with you is one of the oral presentations that was presented to talk about this. I have some, questions about it, so I'm going to kind of talk about maybe some of the limitations or maybe things that they're working on to kind of when the manuscript comes out. But the question is, do GLP-1s have a protective effect? So what they did in this study was it was a retrospective cohort, a global network that they used. And they took women aged 55 to 89 with type 2 diabetes. And they, took the patients into the intervention arm here that had any GLP-1 receptor agonist, and I've listed the prescriptions of the type of GLP-1s. Versus the comparison group was matched controls not on GLP-1s. So all the alternative insulin therapies. And I'll come back to that as a limitation in just a second. And the matching variables, again, they matched for age, race, BMI, A1C, corticosteroid use, tobacco use. And they looked at these patients in 2 years and 5-year follow-ups. And what was really interesting is the study authors said that there was significantly lower rates of fractures in the patients that were GLP-1 receptor agonist users. And this lasted even for 5 years, this benefits. And so, this is very interesting, very curious to understand this this pathophysiology, right, of GLP-1s on bone metabolism. But again, I had a lot of questions when I walked away from this presentation that I wanted to share with you. I mean, is it dose dependent on how long they've been on GLP-1, dose duration, right? You guys understand that. And I think the manuscript will look at this, as well as how you tease out, is it GLP-1 association versus weight loss? They're stopping the other medications. They didn't include some types of fractures. And again, I think the other thing is, are they going to do a subgroup analysis, right? GLP-1s versus SGLT2s, GLP-1s versus TZDs. And so they just kind of lumped all of the diabetes classes in the control arm. So I'm curious there if they'll do a subgroup analysis on it. But there's many papers coming out about this, not just this oral presentation that I wanted to share with you and just get you guys thinking about this. And the mechanisms are also interesting that are being hypothesized. Is the GLP-1 working on this Wnt signaling pathway that I mentioned with romosozumab recently? And again, some of the bone turnover markers have shown that the GLP-1s may be decreasing osteoclast and increasing the osteoblast differentiation. And so I'm actually part of the American Bone Mineral Society professional practice group, and was very grateful to actually, my team looked at the ADA guidelines that'll come out next year. And there is a larger section now on bone health. So I think that's a really good synergy and partnership that the two committees are having. And we definitely, there's definitely a larger section on GLP-1 RAs and bone. So think of this as a little prelude to come. So more to come about this. So I think the main takeaways from the 3 high yield impact topics that I talked about is, again, just going backwards, GLP-1s are neutral. If anything, there's data to show a safer bone profile. So that'll be interesting to see, right? GLP-1s have been shown to show many benefits beyond diabetes lowering, right? Cardiovascular, weight loss, everything. So it'll be interesting to see their bone profile. And then the first topic I started with, right, inpatient SOL after a recent fragility fracture is evidence-based, guideline supported, safe, as long as, again, you check the vitamin D levels, the eGFRs, and so forth. And then finally, I hope I've empowered you all to really kind of reflect and be mindful of which patients would risk stratify as more of the very high or imminent risk and would benefit from an anabolic first. Obviously, there's a place with bisphosphonates, and they're definitely super drugs. But if we could give anabolics first to these patients to maximize their bone density gains, that would be a wonderful partnership with all of you. So that is my talk. Hopefully I've empowered you all to think about this. It's a topic I love, and I'm here for any questions. I have my email address too, if anything comes up later.
Awesome. We have a few questions in the Q&A.
Absolutely.
First question, for romosozumab, do you still give it to patients if they have intermediate to high risk ASCVD?
Yeah, that's a great question. It's really a shared decision making with the patient. I have some patients who are okay with the risk, and again, I document the risk. It was basically in one of the 2 studies, 3, it showed just a slight increase in heart attack and stroke. And all of us are curious, is that just a noise or is there a true signal? And I think there's a lot more studies that are coming out showing, hey, there isn't that risk, trying to understand inhibiting sclerostin and what does that do, for the cardiovascular pathways. And so I really have a discussion. And I've had many patients who say, I don't want that risk. I don't want romosozumab for that very risk. And that's okay too. But I think those are the conversations we should be having with them, and we can help navigate that. There are definitely patients who have said no to me when they have poorly controlled diabetes even, because that's itself a risk factor. So great question.
Awesome. Next question is in regards to the data from the GLP-1s. Did risk of fracture correlate highly with baseline BMI? For example,
Yeah, they didn't show all of that specifics in the oral presentation. Usually these oral presentations are 10 minutes, but that's a great question. Hopefully the manuscript will come out from that Chaudhary group and they can kind of look at that. Like I said, there wasn't subgroup analysis on diabetes classes or other things, so more to come. And it's not published data, so I just had what I heard in the oral abstract.
awesome. And then a question from Judy. I work aggressively on ensuring that my patients on GLP-1 receptor antagonists or agonists to ensure adequate protein intake and resistance
Yep.
exercise. Because
Yep.
everyone ends up having some sarcopenia with their weight loss. And I wonder if this improvement in bone density is due to the increased resistance exercise versus being on the medication itself.
We don't know. Great question. We don't know. I love how people are thinking about this. I recently partnered with a dermatologist to really write about a CME thing about GLP-1s and side effects, including not only the protein loss and everything, but some of the dermatological findings, the significant alopecia, which I don't think we really appreciate as well. So there are many side effects. So I really think it needs quite a bit of a shared decision-making and counseling with the patients to set those expectations. And so, yes, I agree. And we don't know. We don't know which one it is. I've definitely seen the patients that lose the weight loss rapidly are the ones that have the highest risk of the loss of muscle mass versus where it's more gradual, it's not as pronounced. So yeah, great question. Hopefully more things will come out about that. Super. It's an engaged audience, Sri.
Yeah. What do you recommend for monitoring after starting anabolic therapy and when to transition to a bisphosphonate?
Yep. So depending on the anabolic, if it's abaloparatide, it's 18 months. And then usually within a month, I give the anti-resorptive. That's what usually the studies have done. The exact timing we're still looking at of when to give it, but usually we let it a little bit wake up and then give it within a month. For teriparatide, it's 24 months. And then at that time, you do obtain a bone density within the 2-year mark to decide and re-risk stratify the patients, right? Did they have improvement in their T-scores? Are they out of the osteoporosis and into the low bone density category, right? If they are, then perhaps one dose of IV zoledronic acid is enough. And then I can monitor them with the bone turnover markers. So I do use bone turnover markers in my practice for those reasons. But if I haven't gotten them out of osteoporosis and they're still professional fallers or they have new risk factors, then I might have to give them another dose of IV zoledronic acid. But I'm actually a believer, and I think there's some data for this, really the Zol can last up 12 to 18 months. And so again, I'm following the bone turnover markers to be judicious about when do I need to give back the Zol rather than just automatic giving back. I do automatic once a year if I have a very high risk patient that I'm worried about won't get the bone turnover marker labs checked, they're not available or things like that. So again, very nuanced conversations that I think we should be having with our patients.
Amazing. This was a really high yield talk. I really, really appreciate you joining us this morning. That's all of our questions for now.